at this point, Dr. Patel, then tell us what are the options available to a man, you know, who already has developed plaques in his coronary arteries?
Well, the plaques could be at different stages, like Dr. Narula mentioned. You could be at early stage, and you can have preventive measures to stop the plaques from growing. You can also, once you have the plaques, you can have a stress test which would show that there is a lack of blood supply to your heart. Then what you undergo is an angiogram, which a cardiologist, an interventional cardiologist does. And when somebody has a blockage in a coronary artery, what we call as a coronary artery disease, that can lead to either a heart attack or can lead to a chest pain, what we call as angina. When they exert, they can also get shortness of breath, and that is the most common condition which we see in the heart in these patients. So there are various ways of treating the coronary artery disease. One is to take medications to prevent the plaques from developing further, to prevent the plaques from rupturing. As simple medication as an aspirin can prevent a heart attack. When the blockages are severe enough, some of the patients or most of the patients would be amenable to have a stent placed, which again a cardiologist does through your groin. The artery is entered through a groin with a wire, and then they put a balloon to open up the blockage, and to prevent the blockage from collapsing, they put in a stent in it to keep it open. When these treatments are not amenable for a particular patient because of location of the blockages and severity of the blockages, that's when they end up being seen by me. And I'm a heart surgeon, and what I do is I leave the blockages where they are. What I perform, what we call as a bypass surgery. So we leave the blockages where they are, and we take some pieces of tubings or arteries from breastbone, which is called internal mammary artery, or a vein from the leg, and bypass beyond the blockages. So we put it, the blood, reroute the blood to the normal portion of the heart. So whenever in future you develop further blockages or your plaque ruptures, then you don't suffer a massive heart attack. And also when the blood gets more to your heart, you don't get the shortness of breath and chest pain. There are various ways of performing the bypass operation.
Yeah, that's it. I always mystified with that. So please tell us.
So a conventional way of doing this is to open the chest through the breastbone, going through midline of your chest, and then expose the heart, put the heart on heart-lung machine, and then perform the bypass. Nowadays, in the last 10, 15 years, a lot of advances have happened in terms of avoiding the heart-lung machine, which prevents a lot of complications. Again, there are controversies about it, but in experts, in expert hands who are well versed with this technique, who have developed certain expertise in using this newer instrumentation, the outcomes are very good. So you avoid the major complication of stroke, kidney failure after this kind of operations by doing them off pump on a beating heart.
Yes, so pump mean you have to stop the heart.
Yes. To work on the heart, you need to stop the heart.
Because it's moving constantly.
It's moving. Right. However, because the arteries run on the surface of the heart, you can freeze that particular artery on the surface of the heart by using a kitchen or a fork device, which is a modified device, what we call as stabilizer. So you stabilize that portion of the heart and then do the stitching around it. And the newer advances in the last 5 to 7 years is that we use robot to perform this kind of operations. Not all patients are suitable for that. When they need a single or a double bypass to the front vessel of the heart, we can do this using a robot.
Yeah,
so the robot is an instrument which is, as you can see over here, is a long shafted instrument which has got a small little instrument on the tip of this long shaft. This particular instrument goes inside the patient's chest, as you can see in this diagram, and then I, as a surgeon, sit on a console. So these instruments are attached to the robot, and I look onto the console where I see high definition, 6 times magnified image. And then under that excellent magnification and 3D vision, I can do even better work than my eyes can see.
So magnification is 6 times, not
6
3
times
times?
no, 3 times is the conventional magnification, which we loops which we wear. But with a robot, you can magnify up to 6 times, sometimes 8 times.
Really?
So you can do real precise work. The stitches which we use for this kind of operations are very small. They are 1/5 the size of your hair.
Yeah,
so you can imagine how small work and minute, precise work we have to do. And the advantage of doing this operation in a minimally invasive fashion is that you can get to work quickly. You can get up and about quickly.
You don't have to open up the chest.
But most important thing is not all patients are suitable for this.
Okay.
Only people who are experts at it, who are doing this regularly, know which patients are suitable for this, which patients are not suitable for this. The other kind of heart condition which I encounter is the valvular heart disease.
Okay.
The main function of the heart is to move the blood forward. In order for the blood to move in one direction, heart has 4 valves in them, and there are 2 valves in the
one-way direction.
One-way circuit.
Right.
So there can be 2 problems with the valve. Either the valve does not open very well, it gets stiff because as the person gets old, because of wear and tear, there is calcium deposition into it. So the valve, rather than opening and shutting like this, it becomes stiff and does not open very well. And that way it causes obstruction to the blood flow.
Right.
So typically patient will have chest pain, shortness of breath, and these kind of symptoms, palpitations, their heart starts racing. Then the echocardiogram is done, which is called a sonogram of the chest. And that is what determines these kind of conditions. And then either you repair the valve by opening it up or taking the calcium out, or you replace it.
Put a new one.
A new one with a metal or a pig valve or a cow valve. The other condition which we face in these valves, particularly the mitral valve, is the leakage of the valve. And that particular operation, again, we can do using the robot. As you can see in the third picture, is that you typical setup, the robotic arms and a small little tiny hole through which all the instruments are passed inside the chest for me to perform the surgery and reconstruct or sculpt that valve. And the robotic technology gives us an added advantage because you have a much better exposure, and you can actually have your eyes inside the heart because the scope itself can go inside the heart.
Right.
And you can do precise work and sculpt this valve into functionality which is normal.
That is really amazing with robot. But I know you have state-of-the-art robot at Lenox Hill Hospital where you do these operations.
Yes.
So as if you are inside the chest, looking at the heart, 6 times magnified, and doing your precise stitching. That's wonderful.
Yeah, and that also has an advantage because you're making small incision, the blood loss is less. And that is one of the most important things in heart surgery.
And you don't have to stop the heart, as you said.
For valve surgery, we still have to stop the heart because we have to open the heart. We do stop. So typically we make a groin incision through which we expose arteries in the groin to use them as a conduit to establish the heart-lung machine. For bypass operation, because the arteries run on the surface of the heart, we do not stop the heart, and most of the time, 90% of the time, we can get away without stopping the heart, do it on a beating heart.
So now, you see, I know that you are particularly famous for these kind of procedure, and you brought this technology to Lenox Hill Hospital, and I'm sure your number is up on the screen, so any of those guys who need your help, they will call you, including Dr. Nirav. Your number was there. But how long these new procedures have been done?
Well, the robotic procedures have been here in the United States for about 8 to 10 years.
10 years already?
All these things take time for the technology to mature. As the times have gone by, the initial first generation of robot did not have 4 arms. It had only 3 arms. So we had the one more additional arm to retract, to expose the tissues. It did not have the 1080 high definition camera. So as the technology imagine the computers get faster, computers get more smarter and more sophisticated, the instruments also get more sophisticated. They have also got, the instruments have gotten much more dexterity to it because of use of newer computer chips.
Right.
Because what this robot is doing is it's translating surgeons' movements.
What
like
you do
what you do in a
outside.
video game, outside to inside.
The inside, correct.
And it all is with the newer computer chips. And so does it apply to Dr. Narula's practice in detecting new blockages. Now there are non-invasive ways of looking at the blockages like the CAT scan.
That's right. One of the newest ways that we have now is a simple CAT scan that takes about 5 minutes. And with that, we can see directly into the arteries of the heart in a non-invasive way. So patients don't have to have a procedure through the groin.
Really?
Yes.
So you give contrast intravenously?
Exactly.
Okay. Because the definition is so great.
The definition is very good.
So you can see the...
We can see right inside, see if there's blockages in the major coronary arteries.
Well, our listeners, you are looking at the state-of-the-art things here. So get to Dr. Narula. She's going to check out your blood vessels. And if they are blocked, then right next door, Dr. Patel is going to open them up. And it is amazing how medical science has really improved in the recent years. So, are there any complications? A lot of them people are afraid. Just tell them that if they came and you did such a procedure, after how long they will be back to work?
Well, typically after open heart surgery, the recovery time is between about 6 to 8 weeks to get back to work, doing heavy lifting exercise and everything.
In 8 weeks?
In 6 to 8 weeks through the sternum.
That's very early.
Yeah,
Okay.
but if you do it minimally invasive, you can get back to work as early as 2 to 3 weeks. The biggest issue is the psychological fear. Most of my patients, when they come to me and when they see me in the office in a consultation, I tell them, listen, all the other patients who are waiting outside to see me, they are 2 weeks post-op.
Right.
After 2 weeks after the surgery, and they generally travel by subway to come and see me in Manhattan.
Right.
So I think after 2 weeks, there is usually after a week, there is no restriction in walking. Okay. Obviously, it depends upon what condition you were in before. So I just tell my patients that if you come to my office walking and you have open heart surgery, you will be going home in about 3 to 5 days walking.
Walking.
Yeah. There is some pain, discomfort. If you have a traditional big incision operation, the pain is a little bit more.
Yeah.
Again, it is nothing to be scared about.
Right.
A lot of patients come to me and say, oh, I don't want a big open heart surgery. I just want a small operation, even though they are not suitable for that smaller operation.
They don't know. They are not the
Yes,
surgeon.
and I explain to them that my basic first principle is that open heart surgery has a very small, but there is a finite risk of not making through the surgery. Open heart surgery has become very safe these days. So the risk is about 2 to 3%, which is 97% success rate.
Right.
So we tell the patients that I don't want you to be in that 2 to 3%.
Right.
The second principle I have to operate on these patients is that I'm going to make you feel better. You're not going to have the chest pain which you had before, or you're not going to have shortness of breath which you had before, and you're going to live longer.
That's the key. After all, they are doing the
And
operation.
then we can do a smaller incision and have the recovery faster. So these are the things which we have to pay attention to first and then do minimal invasive. Some patients are suitable. I would say 30% of my patients are suitable for minimally invasive procedures, and 70% still get the standard operation.
Wonderful. Well, at that wonderful, optimistic note, we come to the conclusion of our program. And all of you who have watched this program, you wrote down the number for Dr. Narula, for Dr. Patel. Give them a call. Go and see them. Get the advice. Right, Dr. Narula?
That's right.
Okay. Well, thank you for coming.
Thank you.
Both of you, and enlightening our public. Thank you.